which in some respects is one of the most exciting of the sessions that you've had. We're going to first hear an unexpected additional talker who's just going to say one or two comments that appear to be very important. So I'll introduce Ed Wolin, whom you all know, who has some words to say about octreotide.
Just something real quick. There was a little bit of misunderstanding on the part of some people in yeah, okay. There was some misunderstanding earlier, I think, on the part of some people in the audience about octreotide dosing. I think that everything that's been said is totally true, that octreotide is remarkably safe. You can go to extraordinarily high levels, and using 30 milligrams every 2 weeks gives really good blood levels throughout the month. All of that is all true. I just wanted to remind everybody that it's important to discuss octreotide dosing carefully with your treating doctor, because if you use doses higher than 30 milligrams of octreotide LAR every 3 weeks, it can actually make it very difficult to participate in clinical trials, which sometimes offer the best treatment. If you want to be treated on the NETTER-1 trial of PRRT, or you want to be treated with various experimental biologics, if your dose of octreotide is not stable, and in many cases, if it's higher than 30 milligrams every 3 weeks, it's a problem. So just be aware of that. And also be aware that in some states, including California, Medicare doesn't pay if the dose is higher than 30 milligrams every 3 weeks. So be sure to check with your payers if you go too high, because you could run into financial problems. So I just wanted to remind people about that, because it's not totally clear. Not usually. Not usually. No, that's not something I would expect at all. Okay, thank you.
Thank you, Ed. We'll proceed now with our regular program. Our first speaker really doesn't need any introduction. He's known to everybody. He's a giant in this field and is one of the longest who's been involved with neuroendocrine tumors. Tom O'Dorisio is for those who don't know, who is from Iowa and is head of endocrinology and has been involved in many innovations in all areas dealing with carcinoid and neuroendocrine tumors. And he will speak about gallium-68. Thank you, Tom.
Thank you very much, Dr. Warner. And I appreciate very much the title because it's exactly 2 years ago that we introduced the IND that we had at the University of Iowa. And at that time, we were preparing for one study. And what I'm going to do today is bring you up to date on what the protocol that we've done is about and where we are in the next few minutes. So while I was thinking about this, I have a little place in the mountains in Colorado, and every Sunday they have an art fair, and this is a semi-true story. And I was walking down the street, and there's booths on both sides. You know how these art fairs are. And I was actually thinking about what I was going to say for today, and thinking about Dr. Jean, and all of a sudden, the kids were ahead of me, and as usual, and the couples, our children and the grandchildren were strides ahead of me. And I looked over, caught my eye, there was a booth. And the booth was it was a black shrouded thing. And I saw, but I thought the guy said, "Come over here." And I couldn't, so I started to walk over to see. And lo and behold, there was a very large man behind the stand at the booth. He had a tattoo, "Born to Raise Tomatoes." It was right there on his arm. Which is true. And he had a dresser Harley Davidson. And let me tell you, you folks who are aficionados of Harley Davidsons, the dresser is the bike, isn't it? It's got those big leather bags and the double seat. And I mean, it was parked right next to it was a shiny red one. And I just walked up and I looked to see what he had for fare. And a lot of it was things that I'm not too much into, whips and chains and things, things like that. And he said, "I know what you need for your friend." And I said, "Well, you don't even know my friend." He said, "This is what you need to give him." And by gosh, he gave me this. It is called a Debra. It's a rubber duck. It is indeed. And it says here, this is the wording on it. First of all, it says hatched April 26th. And it says, "Zow pow bam, we're talking stampede man." She's one rough, whistling, hoof stomping, head spinning, carousel ride. So see you next time around. This safari is sold out. And he gave it to me. It's a rubber duck. And I said, "I want it." I pulled out some cash. He said, "No, you need a card for this, a plastic card." And I said, "Oh, he saw me coming from right down the road." And I said, "How bad do I want to give this to Dr. Woldering?" And I figured real bad. So this is for him, but I'm going to keep it maybe as a prop toward the end. One thing he did say is, I asked him, I said, "Does it make sounds?" He says, "Not in a normal tub." He says, that's what he said. He said, "It only works in turbulent water." And I said, "Okay," because I knew that Dr. Gene probably took baths in turbulent water. He just did that way. So but this is for Dr. Gene when it's over. And you're all invited to come down and see it. You just can't touch it or yourselves when you see it, okay? So now today, I hope all the handouts are out. I hope everybody has one because the prints are kind of hard to read from the screens. But I'm just going to take up from where we were last year, at this time almost, the principal, and Dr. Bushnell is going to embellish it very much. But I want to just share with you the work at the University of Iowa on the gallium-68 and the IND that we have, the investigator new drug that Dr. Su and the nuclear medicine team of Dr. Bushnell and Dr. Menda and Dr. Graham put together. So we'll just go forward. This is a slide you may see again from David, but it shows on the top octreotide. It shows on the bottom the tyrosinated octreotide. And as you can see, the indium study above, the classic one that we've all done with the OctreoScan, is the pure octreotide that you take regularly, IM or sub-Q. And you'll see that red PHE, that's a phenylalanine, and that's been replaced by another amino acid called tyrosine. This is the original compound that they made with octreotide in Basel, Switzerland, so that they could study octreotide's action in vitro. Tyrosine labels with I-125, and so that's why they put the tyrosine there. We've heard a lot about the binding sites of these, and you'll see a lysine there. Lysine is the binding unit for the receptor subtype 2. That's where it binds to, it locks in a lock key situation. And it's that bottom one that we'll be talking about, the tyrosinated compound, which is called DOTA-TOC. The thing on the end, the DOTA is a cage. Think of it as a cage, and inside the cage, you can do a lot of things. You can put indium, if you want, a slightly different cage, but mostly it's putting gallium inside the cage, and you have a scan that we've been hearing a lot about and people are seeking in the United States. You can take the gallium out of the cage after you get the scan, and you can put yttrium on it, and you have an emitter of about, as Dr. Richard Campeau said, about 10 millimeter of length for treatment. It's a very strong beta agent, and you can put lutetium on it in place of the yttrium, and now you have lutetium-177, Lutathera, which is the study that you've heard about, the NETTER AAA study that's going on. But the point is the arrow is identical in this case. In other words, the basic octreotide arrow, modified with the tyrosine, is the carrier. and the carrier goes in, locks specifically into SST2, maybe a little bit of SST5, receptor 5, but mostly 2 because of the nature of these tumors, that they all are very close to all have the receptor on it. And together it's called theranostics, and that's the approach. The identical arrow with a different radioactive material on the end, and you have a scan with that arrow, and you have treatment. And that's the principle of theranostics, and even for the PRRNT. Now this is hard to read, so look on your sheets, but these are the characteristics, just briefly, between the indium-111 Octreoscan and the gallium-68 DOTA. The resolution is important, because when you do an Octreoscan, it's like looking through the cataract in my left eye, okay? Because it sees down to about 10 to 12 millimeters well. But the gallium sees down because it's a PET scan that David will talk about. It's a different instrument, a different energy, and it has a resolution down to 4 to 6 millimeters. And it's highly attracted to the receptor subtype 2, very, very highly attracted, as you can see on that second box on the left. And the radiation dose is very important because the actual radiation dose is low compared to an Octreoscan in terms of REM and activity, and David will speak to that too. But it has about 1/6 of the radiation dose that Octreoscan does. And the convenience of it is kind of like the 24-hour urine collection, lugging a jug, versus the plasma 5-HIAA, where it takes 24 hours at a minimum to do the Octreoscan with at least 2 trips, 3 trips. You can do the gallium in 45 to 50 minutes, and you're done. So this was what we talked about last year. I just repeat the study because it was published. I'll tell you right now, Europe does on average 10,000 gallium scans a year, okay? A year. And they've been doing it for a long time, since 1997. The problem with Europe and gallium is that they can do it on a tabletop, they can do it on a street corner, and they can do it without a whole lot of reproducible technology, and that's why the FDA did not receive the gallium from Europe, because there was no standard way of doing it. And that's one thing that that was done with creating our gallium-68 here. It was a standard of procedure that we have, and I know Vanderbilt did the same thing without using the instrument, but that's the difference. So now we're starting up the road to get a new drug application for the United States. But this paper is the one I showed last year. They took 84 patients. This was Gabriel's paper. They divided them into 3 groups: detection of unknown primary, biochemical suspicion, if they had it, the initial tumor staging, and they had the number of patients next to it, 36, and post-therapy follow-up. All had the gallium DOTATOC, all had the Octreoscan, high-resolution CT was also done. And then they gave us the methods and the results, and all they say in terms of why they arrived at the results that they did is that these were based on all available histologic imaging and follow-up findings. They don't tell you exactly what they found, but they ended up saying we got true positives and true negatives. And then they said the results showed 97% sensitivity to neuroendocrine tumors, 92% specificity for neuroendocrine tumors, and a 96% accuracy. Now, those are very high numbers in terms of, and I use them. But when you get to the paper and you look at it, they don't really tell you, how they arrived at those. They just said all histologic data was used and all the available imaging was used. So it was not a very detailed study on how they arrived at these very high numbers. Their conclusion was that gallium showed a significantly higher detection rate compared with conventional Octreoscan, and that was the paper. So based on that, we started our work. Last year I showed you this information, and it's now published. What we wanted to look at very simply is, if I did a gallium this week on a person, and a week later did another gallium on the same person, in other words, within the same person, done twice, how good is the reproducibility? because you want to know that if you have a gallium a year ago and you've had something done to you in between, and we do another gallium on you, you want to know that that's real, a reproducible result. And what we showed was we had 5 patients done twice, week apart, and we calculated a lesion. We counted the lesions very carefully. Dr. Minda, Dr. Bushnell in nuclear medicine watched the study very carefully. We used the same lesions, and we quantitated them. And the intraclass, that is between the same patient, the coefficient of variation was 0.99 if you use the maximum uptake in known tumors. In other words, they call it standard uptake value. And if you use that number against the same tumor in the same patient a week later, the reproducibility is almost perfect, 1 being perfect, the correlation coefficient. So we felt very, very good that the reproducibility in the same subject was the right way to go. Now, this was the last slide I showed you last year. And on the right side is the Octria scan, and on the left side is the gallium DOTATOC. And you can see, as you look at it, it's on your left side below the tip of the liver. You can see a dot with the gallium-68. And this is what intrigued us. And now you can see it better in a cross-section. I think Dr. B is going to talk about it again. But in the lower left panel there, on the first set of panels, the lower left, you can see very clearly the unknown primary tumor being the carcinoid tumor in this gentleman, who it was unknown that he had metastasis, but we couldn't find the primary. And this was the last patient that we did, and it was found, and he had surgery, and it was proven. Let me just go forward. So we took our protocol, and our indications were safety and efficacy, known neuroendocrine tumor metastasis, but no primary, suspected neuroendocrine tumor not identified by conventional testing with 1 or more abnormal markers. That's the 3rd group. And the 4th group was staging for surgery or peptide receptor nuclide. So we tried to reproduce that paper from Gabriel. And what I'm going to show you are the 3 indications and what our results are so far. This is all preliminary data, but this is where we've come. For indication of safety and efficacy, 200 patients have been done. We've done 190 that are complete, and 120 have been analyzed, all with known neuroendocrine tumors, all with chemistries before and after the performance of the tests, and they were evaluated statistically. Let me just turn this beast off. Okay, there. Hope it's empty. Good. Most common possibly related grade 1 event was flushing, diarrhea, abdominal discomfort. These were rare in the 120 we've analyzed. It's possibly related. They were all transient. We had a possibly related grade 2 event. I'm sorry, let me just turn that. Hit that thing. Just turn that button. Beat it to death. So the most common possibly related event was the flushing. The next most common possibly related grade 2 event was a slight increase in liver enzyme in the AST. And the only grade 3 possibly related to the study drug was a decrease in platelets. And these were all transient. They were all the ones that we've analyzed so far, 120. In other words, it's extraordinarily safe. The claustrophobia is not an issue. You can use a little bit of Xanax if you need it, so a patient can lie under the machine. It's not an MR machine. It's opened on the sides. But it's really safe, and I'm sure Eric's 60 patients, he would say the same thing. But based on this information, next week we're going with the data to the FDA. It is hoped that they will accept the safety and efficacy from one center, and this will now open the door for both the gallium DOTATOC and the DOTATATE. And it's our goal and design that the American Society of Nuclear Medicine will get this, and we'll have what they call the new drug application. This should be coming very soon, we hope, and that they will be able to give out any nuclear medicine place in the country that want to do it, and they can all be charged for against insurance. And so we're very, very happy about it. And again, the player on this is Dr. Sue, because she's given up the investigator new drug to the Society of Nuclear Medicine. And because of our nuclear medicine force with David and Michael Graham and Yusuf Menda, this is going to be possible, and the cooperation of Vanderbilt as well for the dotatate. The next thing we did for the next indication was no neuroendocrine tumor, but no primary. We have 20 patients that we've had with histopathology of neuroendocrine tumor mets, primary not determined. By CT, MR, Octria scan, we only did those in 8 patients, but could not find the primary. 9 out of 14, 45% gallium-68s were positive, as you can see, and confirmed by surgery in 6. 2 others of the 3 have been operated, and the primary tumor has been confirmed. So it's really 11 out of 14. Okay, there was 2 false positives and 3 unconfirmed, and I told you the 2 of the 3 have been confirmed. So we have clearly shown that with all conventional imaging, and again we only used 8 Octria scan patients at that time, but because of that, we've gone forward, and I'll show you the protocol designed for the next year. Finally, suspected neuroendocrine tumors and gallium PET. These are 22 patients that had suspected tumors. They had carcinoid/syndrome, carcinoid/complex, loose stools or diarrhea in 22 of them, flushing in 21, elevated serotonins to about 300, never higher, elevated chromogranins barely above normal, and all had negative CT, MR, Octria scans. The gallium was negative in 21 out of the 22 patients. 1 pancreatic uncinate was read as positive. It was a false positive due to the high intensity of the pancreatic polypeptide cell, which can make it look like a focal lesion in the head of the pancreas, and it was negative. And the other thing that we've noticed on these patients that we've done is that they come in with a history of higher and higher doses, escalating octreotide doses. And it's remarkable because they've all had step-ups. Some have been on the pump as high as 13 units an hour for this, and that's 23 to 2,500 micrograms a day, and they keep escalating to control their symptoms. And it's just a phenomenon in this group, but they have never been shown to have the tumor. We've now stopped doing them because they've just all been negative without at least a CT scan showing something or an Octria scan showing something or an MR. So our next study is the one that we've started, is that we're comparing the gallium toe-to-toe with Octria scan, done within a week of each other. And so far we've enrolled 45 patients. This is a grant with the same IND, and these are being evaluated. We're doing them right now, and we'll be able to see the value of the gallium against the Octria scan in terms of where is it better and where is it helpful. So this is a real toe-to-toe against the Octria scan itself, and we've done 45, and the data is still being accrued. This study is I think my last slide, actually. I have second to the last slide, but this is the phase 2 therapeutic trial where we're going to be using the yttrium-90 DOTATOC peptide receptor radionuclide therapy, PRRT, in children age 2 to adults age 90 with neuroendocrine tumors and all tumors that are somatostatin receptor expressing. That includes children with medulloblastoma, glioblastoma. It includes all tumors that are SSTR positive. So it's an open phase 2. We intend for it to go until the until the approval of the FDA for the Y90. And this study is designed, you don't have to show progression. That's been talked about, how far along these patients are when they get the PRRT. It's we're going to be moving that clock back and treating them sooner. They do not have to be progressing, and that's a big thing. They can be stable with one identifiable lesion, and there's no control on this. Everybody gets the Y90. and we're very, very pleased with it. And again, it's the work of Dr. Sue and her investigator new drug that she has for both children and adults. She's the only place in the world that can treat the children with this. And it's with the cooperation of Dr. Menda and Dr. Bushnell and our nuclear medicine team that it'll happen. We're very excited about it. And they've talked a little bit about maybe more safety with the lutetium. But this study is designed very carefully so that after the first dose, standard dose of Y90, there'll be dosimetry on the kidneys and the marrow, and we will then adjust the next two doses, the next two therapies, in a customized way. So patients may get more or get less of the next two doses. And we, in our first series that David authored, our first work with this, our phase 2 international, we had only two grade 2 renal problems with our patients in that study. There were over 98 patients in it, and they both were reversed. So we have never seen the renal toxicity that was described early on with Y90, and we won't see it with this study either. It is set to open in 30 days. So we'll have that. And people have asked, where do you find out about these things? I think you saw it on the bottom of the sheet, www.clinicaltrials.gov. When it hits that website, it's ongoing and up and approved. So that's one way that you can follow this and find out what's available throughout the country. That includes the studies that you heard yesterday from medical oncology. All of those trials are in there and can be found when they're up and present. This one's for Dr. Gene. He's asked several times, real-time analysis of 46 patients undergoing the gallium for staging of disease. Does it make a difference in terms of what you do next with what you know? He's been asking that for a year, and so far we've done 46 patients, Dr. Gene. We followed them pre and post gallium PETs, and the final report, major change in management we found was done in 17 of 46 patients. 37% of the patients that had the gallium had a change in management of their tumors. Surgery for primary, surgery for recurrence, referral for PRRT, or even cancellation of surgery. And this was all done in a prospective, retrospective fashion. And this one is, I think, starting to answer the question that Dr. Gene has raised. Does it make a difference does a gallium-68 make a difference in management? It's a great question, and we're teasing a little bit of it out, and we hope that it holds, but we're seeing 37%. And so I'm going to stop right there, and thank you very much for the opportunity.